You're listening to the UBC Medicine Learning Network.
Before we start the interview today, I would just like to acknowledge that we are hosting this on the unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. Welcome. You're listening to Metamorphosis, a podcast where we interview physicians from across BC and Canada with the aim of helping medical students navigate their medical careers. My name is Igor, and on today's episode, we are speaking with Dr. David Mongar, a family physician working in maternity care, addictions medicine, as well as general family practice. Welcome to the show, David. Thank you so much for being here.
Hey, Igor. Thank you so much. It's my pleasure.
How are you doing today?
I'm good. It's my day off, quote unquote off, where I just sort of manage the kids in the house. So pleasure to be here. Yeah,
it's great to have you. So on today's episode, it's part of our larger series on the flexibility in family medicine and the different kind of subspecialty options that are available. So you do a lot of maternity care in your practice, and you also do a bit of addictions medicine. So to start off, maybe you can tell us a little bit about kind of what your general practice looks like. Maybe you can just give us a sense of what a typical week looks like for you, to give our listeners an idea of how you've structured things.
Of course. So right now, I'm my fifth year of practice. I'm still officially a locum. So I'm leaving myself a little bit available to sort of cover other people's practices longitudinally. So my longitudinal full service family practice is generally sort of a Monday, Tuesday kind of thing. And then on Wednesdays, I work in pretty intense addictions in the Downtown Eastside. I'm at a housing facility there called the Portland Hotel. Where I do fairly long, fairly involved days on Wednesdays. And then on Thursdays, I recently started regularly picking up at Sheway. So I do a half day on Thursdays at Sheway doing perinatal addictions. And then I finish off my week either doing a full day of maternity clinic at Burnaby Hospital, or working a 24-hour call there. So I have kind of an ombre end to my week. I go addictions, perinatal addictions, and then just straight up maternity care on the Fridays.
Wow, that's really interesting. Can you tell me a bit more about that Center for Perinatal Addictions? I haven't actually heard of that one.
Sheway is it's on East Hastings. It's very much in the thick of things, and it's providing care for women and birthing people who have addictions issues, and so we provide a lot of addictions care for them, but also for their whole family. And so we'll provide a lot of care for their babies when they're born, for their kids when they come in with coughs and colds. And so we work in a really comprehensive team there. There's social workers, there's dietitians, there's nurses who are incredibly skilled. There's a pediatrician who's there most days of the week. And there's a few of us family doctors sort of spearheading everything. So it's a really, really wonderful, very holistic place where people can gather in a very sort of low barrier way and have all of their needs taken care of under one roof. It's a joy to work with a team that's so skilled.
Wow, that sounds incredible. And sounds like a really interesting mix of kind of the two things that you're interested in, which is maternity care and addictions as well. So how did you kind of get into that, or how did you find out about that was an option?
Yeah, it came a bit later, actually. I had the two sort of, the two poles kind of separated initially when I first started in practice. So I was doing addictions care sort of right off the bat. I found that later in residency. It was actually in my R2 year. I think I did my addictions rotation in February or March. And then by July, I was so in love with this that I said, okay, I would definitely want to have this as a big part of my practice. And so I ended up working in the Columbia Street Clinic for a little while. And then doing addictions care by taking over a patient panel at the Portland Hotel. And then I happened to do a maternity leave for a friend and colleague. And they had a panel of people who were years out from Sheway in their regular family practice. And then also part of doing that locum was delivering with Group 2 at BC Women's, which works really closely with the FER ward there. And then doing shifts at Sheway, so covering the Sheway shifts as the family doctor there. Completely fell in love. Would never ever want to leave, and so I've been really fortunate to sort of work that in as a longitudinal part of my practice now. And then I'm sure a lot of family docs sort of find this, but you start as a locum, you start broad, you start sort of not committed, working from practice to practice, and then you pick up things that you just love and you could never say goodbye to. And so then, your free time and your ability to take on someone's full practice sort of dwindles over time. So if a colleague said, can you cover me? I'm going away to Greece for 4 weeks. I would say I can cover a couple days, but I'm committed to my patients at the Portland Hotel. I'm committed to Sheway, and I'm committed to my maternity care that I now provide at Burnaby Hospital. And so, unfortunately, do get a little bit wedged in, not able to take on a full week's work of practice for someone, but you can definitely chip in a bit by bit.
That's fantastic. Yeah, I've actually heard that from quite a few people that after, quite a few family physicians, is that after residency, they recommend you do a bit of locuming and just kind of explore the different options, see what's available, not like ground yourself right away into something, but just kind of go around and explore and see what fits your style the best and what you enjoy. And it sounds like that really worked out really well for you.
It did. I'm overjoyed to have this practice and to have this variety that from Monday to Friday is just completely different flavors every day. How I'm getting to work, whether I'm cycling or whether I'm driving my car, where I'm working, whether it's in the hospital or, literally in patients' rooms in the Downtown Eastside, which can be a real eye-opening, window into their health and into their life. It's every day is something completely different, which really suits me for having a very short attention span.
That's fantastic. And when you were applying for family medicine residency, were you planning on just doing kind of comprehensive family medicine, or did you know that maternity care and addictions were something that you wanted to do in the future?
I didn't know the addictions piece, funnily enough. But as I said, that was something that came a little bit later in second year of residency. Maternity care, I've been fascinated with for my life. I remember conversations going back to elementary school with my mom about how I was born and how my brother was born. I was always fascinated. And then it was first year med school, the maternity care nights that they used to hold at Women's. I'm not sure if those are starting back up again, but they basically they provide a stipend for a few people who are pregnant to show up, and you do Leopold's. There's the on their babies. And I remember the first time I felt a baby kick when I was sort of trying to figure out if this baby was breech or cephalic. And yeah, it was a real life-changing moment. It was, I think I cried a little and then knew that was definitely something I wanted to have as part of my practice eventually. And then through med school, I think most people in med school, by the end of it, they know whether or not they want to do obstetrics as part of their practice. I think it's rare that you'd have a resident who came in saying, I don't want to do maternity care at all, and then comes around and does a 180 there. I do find it's fairly polarizing. Either you love it or you hate it. But yeah, I knew fairly early on that I wanted to deliver babies. And then the question for me was, do I do this as a family doc and get to continue to take care of families and babies, or do I go the OBGYN route and become a surgeon? And I chose family medicine.
Yeah, probably, I guess, a good choice then. Yeah, it seems like you really enjoy what you do. Yeah, I'm always interested in hearing, how people discover these pathways and things, because I feel like in my class, probably in a lot of medical school classes around Canada, a lot of students don't really know what the options are in family medicine and how you can really tailor your practice and do the things that you enjoy. So it's really good to hear that you went to one of these sessions and they inspired you to pursue this in your future practice. So I guess that's a shout out to the maternity care nights and a lot of these other types of similar sessions as well for different subspecialties. So it's great for students to attend these types of sessions. If you're interested in something, definitely check it out. You might end up doing it in the future.
Yeah, and if it grabs you, then you just sort of figure out how you want to work it in. What kind of doctor you want to be, what kind of team you want to work in, and what kind of environment. And I will say that I was pretty torn. I kind of double matched OB into family, and it was actually on the CARMS tour itself that I really decided that no, I wasn't happy saying goodbye to families. I wasn't saying goodbye to happy saying goodbye to taking care of babies. And so I really wanted to, keep myself broad and sort of holistic and not do the 5-year grind of a surgical residency. So not only was I glad sort of throughout residency to sort of, find my people and become a fully fledged family doctor, but I will say that in terms of, how I'm able to provide maternity care, it's rare that I have a shift where I'm not grateful to have chosen this path. It is so nice having someone to call in the middle of the night and bring people onto the team. I think I would have found it fairly isolating going the other route.
Yeah. So what is it that you find the most interesting about maternity care? What drives you to do the work that you do?
It's delivering babies, it's taking care of families, and it's seeing those transformations that I find so rewarding. And there's nothing else like it. There's nothing else where someone comes into the room, not being a parent and leaves with a baby. It's really bearing witness to incredible change and incredible strength, and people doing things that they had no idea they had the fortitude to do. It's completely life altering. And you're there, you have a front row seat. It's quite emotional. It's quite moving. You get a lot of great opportunity for some really involved counseling, and you get to take care of people not only in their happiest moments, but also that you're there. There are sad times in obstetrics, in maternity care, and that's very rewarding to be there to help facilitate and to help people get through that. So there's a full spectrum, and yeah, I think it's a great honor. And also, there's just nothing else that I would rather, wake up at 4:30 in the morning, and jump out of bed for, with a big smile on my face. There's nothing else that would do that for me. So yeah, I count myself as very lucky.
Yeah, I agree. Doing my obstetrics rotation, I definitely got to see that whole spectrum of joy and also pain. And, it really is life-changing, the whole experience. So definitely really interesting field. So how does it work? You see your patients kind of during pregnancy in your clinic, and then once they're in labor, do you go see them in the hospital, or are you just on call sometimes? How does that work?
Yeah, I think back in the day, and I actually had the joy of working with a provider who was a full service family practice, cradle to tomb, and would be seeing patients in their last days of their life, providing their palliative care, and then get a call from the hospital saying that one of his patients was in labor, and literally would just cancel his afternoon clinic and cycle to the hospital and deliver a baby, and then try and make it back to see his last few patients for the afternoon. It was just really, really incredible. I think that's quite rare these days, that people are seeing their own patients for their prenatal care and then delivering them as well. So most people work as part of a group, and that group will be based out of a hospital. And then usually, I would say, there's a clinic that is providing all the prenatal care, housed or staffed by the same docs who are actually going to end up doing the deliveries. So that's how it works at Burnaby, which is where I found myself permanently. And you're providing all of their prenatal care. And then that, if you're taking care of this family through the pregnancy, that you might actually get a chance of being the doctor who's on call for the 24 hours where they deliver their kid. So you really keep all of your skills quite well honed, having that mix. And I think the patients are really grateful for sort of that, having that mix, having that holistic care in the pregnancy, and then having that opportunity to have their intrapartum care provided by the same group.
Mm-hmm. Yeah, and it must be a really special feeling too when you have the opportunity to deliver a baby for one of your own patients who you've been seeing in clinic.
Yeah, it's lovely. I mean, you see so much transformation that goes on in pregnancy itself, from that first prenatal visit all the way up until when they're just kind of really eager to going through labor incredibly. But you're seeing them in their last weeks of pregnancy, and then getting to be there for the delivery is really special. And so, certainly back in the day, there was more of that. There was more of, delivering your own patients and then seeing them, seeing their babies grow up, and then maybe delivering them later down the road if you were in it for long enough. So I think we're probably seeing less of that, but we are seeing a better quality of life, right? Not always being on call 24/7. Right.
Yeah, and I think that's very important as well, just to kind of minimize the potential for burnout, because I know that being always on call, it can be really tough long term. But it sounds like the fact that you vary your practice quite a bit probably helps stave off some of those
I
feelings.
think so. I think every day of my week is a little bit exciting. It's something new, and it's something I sort of haven't done for a full week. So I definitely, I have a certain eagerness to me before every shift, which is great.
Awesome. So, what are some of the biggest challenges that you would say are there working in maternity care?
I think the fact that you can do a 24-hour shift and you can be busy for the entire thing. You can be working constantly from 8 a.m. to 8 a.m. the following day. I think that is something that is, not every specialty has that. A lot of specialties do call overnight, but they get to sleep the next day, or they'll do call overnight, and have that sort of, just be 12 hours, or, if you're an emerge, 8 hours. And, we definitely work hard, but it does minimize, the amount of handover you have to do. And it does allow you to be there to see the full arc of a lot of people's journeys. You have to be willing to get into the thick of things. You have to be willing to be covered in, blood and bodily fluids of all description. And I think that's kind of rare. It's a bit messy as a specialty. I actually left BC Women's one shift, where I was locuming before, and I didn't have my wedding ring, and my wife noticed my ring finger was bare, and she said, "Where's your ring?" And I said, "Oh no, it's in my scrubs." And I was only able to
Oh, no.
cycle back to the hospital, go to the laundry bin where I had dropped my scrubs, and find that same set of scrubs, because they were green, coated in meconium stained amniotic fluid. There's just nothing else like it. So I think there are challenges, like that. But just so balanced out by the joy of everything that I'm eager to see sort of every week.
Mm-hmm. Probably the one time you were grateful to be covered in meconium at that point.
Absolutely. Yeah. Clutch. Thank you, baby.
Amazing. Yeah. And I was also wondering, in terms of, because you mentioned some of the challenges include the shifts and things like that. How free are you to organize your own schedule, make your own call shifts? I know you work in a group, so what kind of dynamics are there in terms of the freedom you have to create your own schedule?
Yeah, I think that the call shifts are generally sort of, up for grabs, generally in a somewhat regular repeating fashion. And you always have some degree of, of autonomy of deciding sort of which day of the week you're going to settle into as part of these groups. And then also when you're going to pick up for vacation. And there's a lot of give and take, and there's a lot of, collegiality behind, not wanting to leave people, high and dry. For example, there was a person in my current call group who, just got sick and had to ask the group, is there someone who can cover call for tomorrow? And sure enough, someone, stepped up to the plate. So ideally you work in a really collegial group where there's that flexibility, but you really decide sort of how many call shifts you want to do a month. There isn't, a set requirement, and you can sort of be as involved or not involved as you want to be. There's a lot of flexibility.
Mm-hmm. And how does it work in terms of communicating with obstetricians or other specialists during a pregnancy? What's kind of the dynamic there as well?
We work really closely with our colleagues. We're really lucky, at all of the hospitals I've worked at, actually, to have really collegial groups. Everyone is generally really happy to come in and join the team. If you need to consult OB internal medicine or maternal fetal medicine throughout the pregnancy, or OB, people are always really willing to sort of help chip in. And the ideal is that, for us providing low risk obstetrical care, that we are still leading the care, that we're still sort of team lead, conducting everything, and that you're able to bring in your specialist colleagues to help and advise and help you make good decisions, and certainly help, towards the later part of pregnancies in terms of, planning deliveries and everything. But you're left sort of still being the patient's sort of number one contact. And so a lot of it is through, fairly traditional referrals, but then you're always able to sort of, get someone on the phone and go over a challenging case and make sure that you're making the right decisions. And then there's a lot of working really closely when you're on labor and delivery in the case room. If someone comes in, they've got a particularly challenging angle to their pregnancy, then our colleagues are always there. We're really pretty tight, good team.
That's awesome. That sounds like a really nice collegial environment, and it must feel nice to have access to those specialists in the case that there are more complicated or difficult deliveries. You yourself, are you delivering more of the low risk pregnancies? Do you ever take on any more complicated stuff?
I think the goal is to do the low risk stuff and to have that really be covered by family docs and midwives, and have the OBs sort of doing the higher risk, more challenging, complicated cases. In a lot of cases, will remain MRP even if the patient does have some complexity to their prenatal care. It's quite rare actually that we will consult OB and they'll say, "Oh, let me take this," unless there's two babies. Twins is something that we would just like never handle as a family doctor in an urban setting anyway, and so that's always handled by OB. So we always transfer care if they do find two fetal heart rates. But otherwise, we're pretty much left to take care of people, even if they are fairly complex. We just do it in close relationship with our obstetrical colleagues or our OB internal medicine colleagues as well.
Mm-hmm. Yeah, I don't know if maybe you can think of some particular challenging or difficult cases that come to mind that you've had to deal with in your practice.
I mean, there's always challenging cases. I think the most challenging cases are where you're I don't have a specific example, to be perfectly honest, but I think that the challenging cases are where you're really advocating for the same thing that the family's goal is to have a healthy baby, healthy mom, right? And you come in with your level of expertise and evidence-based knowledge, and you can see that people are making decisions that sort of deviate from that. And so I think some of the most challenging cases are where you're really trying to communicate. But hitting prior biases, or hitting hesitancy that's there for whatever reason, for whatever this person has gone through, and you're trying to help them navigate in the safest possible way, but aware that informed consent and that shared decision making, it really is it is really their body and their baby, and they really do get to choose. You just try and help them do that in a safe way. And I think in the vast majority of cases, with the right kind of counseling, I think you really can help mitigate those safety issues and really help people come to sort of what I would view as like the right conclusion, or the safest conclusion. But certainly you feel you've got a stake in it. You really want things to turn out well, and you have the experience to sort of know how quickly things can go south, for example. But I'd say that's rare. Most people are fairly reasonable when it comes to making safe decisions.
Yeah, that's good to hear, because these are really difficult situations sometimes, especially when you as a physician might feel that there's a particular route that's more safe or makes more sense, but then the patient is maybe pushing back on it a little bit. Do you have any thoughts on how to approach these types of situations in terms of the shared decision making? Are there any strategies that you tend to use? Do you find this to be a challenge?
I mean, it can be challenging, especially if people feel like they're having to push back and advocate for themselves, and they feel like you're coming from another angle. And there's that digging in sort of paradigm that we've seen with a lot of difficult conversations, especially over the past few years, for example, about vaccines. But I think if you really just keep coming back to, the things that are keeping you on the same page, you really keep coming back to find that common ground, and you angle everything from that standpoint, I think that you can have much more productive conversations. And so a lot of echoing, a lot of active listening, a lot of rephrasing or paraphrasing, and then just coming back to that, we're on the same team here. We're really going for the same thing, and helping sort of guide from there. I find that's really helpful. I find a lot of open-ended questions at the beginning of the conversation. I was going to touch on, people will come in with birth plans, for example. And, I think there's a certain level of, skepticism maybe from other providers where, no, birth plan, what's this going to be about? And I'm always encouraging patients to do that if they feel that's going to be helpful. Knowing in the back of my mind that if they come in with a birth plan, chances are very, very good that everything that they want is what I want as well. patients will come in and they'll say, well, I want, delayed cord clamping. And I want, baby to be placed skin to skin immediately. And we don't want any unnecessary episiotomy or vacuum or forceps. I'm like, me too. Like, that's exactly where I come from. And so it's actually a really nice place to build that common ground. It's nice to sort of, come from that position and then say, I know that you want X, Y, and Z. I want them too. And here's, I think, our best route to actually get there.
Yeah, and I think patients are a lot more informed as well in a lot of ways these days, just with so much information available. People are really conscious about this stuff and they get involved in their own care, which I think is awesome as well. It's really great when a physician is kind of on that same wavelength in terms of meeting them where they're at and trying to find a shared decision that everyone can be comfortable with. Yeah, exactly. I think that's awesome. I wanted to ask as well in terms of urban versus rural care. So how did you make your decision? I assume you practice mostly in urban settings. Do you do any rural maternity care as well?
I did a little early on in my career. I think in my first year of practice, I did a couple weeks up in Yellowknife, which was really exciting, really like a wonderful city to visit and practice in. A really amazing group of very collegial docs running things up there. Very connected to other health authorities and other specialists sort of remotely as well. I knew I wanted to remain urban just because I wanted to live in Vancouver. I wanted to live in the Lower Mainland. I wanted to have a fairly high volume obstetrical practice as well. And so I've been able to do that because of, burgeoning populations here in the Lower Mainland, which I think I would have had a hard time to find necessarily rurally. So I wanted, to be on call sort of about once a week and be busy on those calls. And I think it's a little bit more stretched out maybe in a rural setting. I will say a piece of advice that I give to every learner that I come across is if they are thinking about family medicine, if they want to be done in 2 years, that as much of that training that can happen rurally, the better. The growth that you see in residents when they come back from their rural rotations, and I'm talking about myself here as well, is exceptional. And so I think going far and going remote for training is crucial and really, really helpful. I had to balance a little bit of that. I did my rural rotation late, sort of in my I think it was my second year because we were studying for our exams. So I wasn't really exposed to it too much, other than, our med school rotations until fairly late. But looking back, I think I did 2 months and I did something absurd, like 400 hours, even in the first month. So it was, you worked really, really hard, but the transformation was incredible. And I think if I could have done double that, if I could have done 4 months, I would have, if I found it a little bit sooner. That being said, I was, really driven and passionate about obstetrical care already. So I did definitely try and structure all my electives towards, delivering as many babies as possible and getting as much experience under my belt as possible. So that sort of precluded going rural for the entire thing, but it did allow me to sort of hit the ground running in July, right after graduation from residency.
Yeah, that's a great insight, because I've actually been doing a bit of research on my literature review on this topic, and it seems like a large percentage of graduates of core family medicine residency don't actually feel comfortable practicing maternity care independently after residency. And so I guess getting some of that rural practice is really key to maybe bringing yourself up to speed. And because I guess 2 years in family medicine residency seems like not a long time to really master a lot of these skills.
Yeah, it's short. It's short. Which is one of the pulls, right? That's one of the reasons, I remember being my last a little bit of med school and thinking I'm already tired. How could I do 5 years? I think I can manage 2 barely. So, but you're right. It is short to sort of to build up that entire skill set. And I think there is, probably a degree of necessity in specializing somewhat throughout your residency. It's I think it'd be very challenging to go into sort of every little angle from family medicine just within those 2 years. I was able to sort of angle myself fairly heavily towards providing maternity care in such a way that I wouldn't say comfortable. Comfortable is a tricky word. I wasn't comfortable in July of, right after graduation delivering babies, but I was, I felt competent. I had done it enough that I knew that, with a good team around me, working closely with my obstetrical colleagues, I would able to, deliver good care. And then the other piece is that, we don't function in a vacuum. We function as part of a community. It really does take a village. And one of the things that I tell, people who are wanting to do maternity care is you will have, a WhatsApp group or some sort of hive mind that you can tap into when it's 3 a.m. and your brain is a little bit broken and you're sort of, wanting just a sounding board to bounce some ideas back off of, because there will generally be a community of colleagues across the province or country even who are also passionate about doing what you're doing and are also, brave enough to sort of, or stupid enough to start in July, right after graduation. And so that was something that we continued on with, that sort of community aspect. And it was definitely helpful for people who didn't want to add on like another 3 months, for example, or another year.
That's awesome. I know that a lot of residents use WhatsApp groups and things like that amongst themselves in residency for the same reason, but it's really nice to know that those things kind of carry on into practice as well. So you have that extra support from your peers when you need it in practice. That's really nice to hear.
Absolutely. Yeah, you're never alone. And I mean, that's one of the beautiful things about both of the angles that I have in my practice, that they're both like very team based. And I wouldn't trade that for anything. So in addictions, I work with, a nurse, sometimes a pharmacist, in the Downtown Eastside. So I'm never really alone there. We're always working in a team. And then, at Sheway, I've talked at length, I think about how collegial and how interdisciplinary that team environment is to take care of women with substance use disorders in pregnancy. And then on any obstetrical floor, it's always a team. You're always in team with the nursing. You're always with the nursing staff. You're always in team with your obstetrical colleagues. And so it really does. It's warm and fuzzy. It's a family. It's something that I would never be able to give up for all those reasons.
That's wonderful to hear. Yeah, and I also just wanted to ask, just finishing off with the maternity care piece. I just want to know, maybe on a systemic level, if you think that there's anything we could change or the government could change about family medicine residency to incorporate more maternity care to get residents more up to speed with their skills and just feeling a bit better about entering independent practice. Do you think that that's necessary, or do you think that, like for yourself, for example, you were already interested in maternity care, so maybe you had some more electives or something that helped you improve your skills, but for somebody who's not super focused on maternity care, is there anything you think that should be done to bring them up to speed as well?
I think as part of any residency program, there's going to be an obstetrical rotation. I think, for those who aren't already passionate about it, I think it's unlikely that those like 6 weeks or 8 weeks, I guess, that they will sort of, turn on a dime and decide that they actually want to, deliver babies as part of their professional practice. But I do think, providing that is important. I think provision of maternity care is important, sort of no matter what you end up doing, even if it is just for early pregnancy. And there are incentives to delivering babies there. Although you pay more for your CMPA dues, that's almost all covered by stipends that you get throughout the year. They just recently went up on our fee rates for visits for prenatal visits as well as postpartum care. And then there are continuing incentives just for being a doctor who delivers babies. Your first 25 babies, you get bonuses basically for every one of them as ways of sort of enticing people to continue this as part of their practice. So I think for those who do want to do it, there's definitely there's all the reasons sort of I've gone into before, and also it to be perfectly honest, you're rewarded for doing 24 hours covered in amniotic fluid. Um, and so, ideally the things that, you love and you want to keep as part of your practice, they're also, you're not hemorrhaging money to do so. And I think obstetrics is one of those examples where they've actually done a good job of making it, a rewarding specialty for every reason, but also, well compensated. And I know that like every health authority is currently on the warpath to make sure that family docs, continue to be able to provide really good holistic maternity care. I know that there are big initiatives for sort of, building communities, building, listservs and having people be, be able to be connected to all the other, maternity providers in their area. And I think, with that increasing strength of those networks, I think you're just going to see it reinforced. And if new grads are at all passionate about maternity care, I think they'll be well rewarded for continuing that as part of their practice.
Well, it's good to know that being covered in amniotic fluid isn't the only reward for doing maternity care. So that's nice.
It's not. Yeah, no, it's just a little side bonus.
Awesome. If we could get into a little bit into addictions medicine as well, maybe you could tell us how that worked out for you. Did you do any additional training in addiction medicine, or did you just jump right into it after residency?
So this is another one of these like community, like the village really took care of me. I had done, I think, 2 weeks of addictions as part of our family medicine residency. And then immediately after those 2 weeks, I was passionate enough to sort of book an elective where I ended up working immediately in July of right after graduation. And, I'd had 4 weeks of training in this area, and had a big soft spot in my heart for, folks who have experienced trauma and are marginalized and dealing with substance use disorders, and was able to sort of hit the ground running in July, backed up by this incredible community of support of people who had one day, at some point been just like me, and who were willing to kind of treat me as a glorified resident, as a staff family doc providing addictions in the Downtown Eastside. So, I found incredible camaraderie there, again, working with just remarkably skilled nursing colleagues, and in a team environment that was really able to sort of facilitate this incredible knowledge curve or learning curve. So that's sort of how I found my way in, and then, providing care to people in their homes or in their building. I found that was something I experienced briefly as a resident, and I knew I had it in the back of my mind, eventually I want to be the family doctor for a building and just take care of folks where they live. And I was I was really lucky to have found my way into one of those housing developments. I think by my second or maybe third year of full staff sort of family practice. So that's how I sort of found my way in there. And then I think I talked a little bit about how I found my way into perinatal addictions. And then, there's nothing else that I've seen, there's nothing else through which I've seen these kind of transformations, right? So I was doing a locum for someone who was taking care of, Sheway patients years and years and years after. And, as I'm filling their Suboxone or their methadone and checking in with them, when was the last time they used opioids? I can't count the amount of times they would say, it was my last, few weeks of pregnancy, or just before my son was born, or just before my daughter was born. And here they are years later, having had that, that experience of being taken care of by Sheway or by, the Fur Ward or, Ron Abrahams or any of the wonderful physicians that they have working there. And that was the turning point for the rest of their life. And here I was sort of bearing witness to that years down the road. And so, yeah, it's a really powerful area to work in, whether or not someone is dealing with perinatal addictions. I talked about sort of that transformation that happens within that family, within that person. But especially, folks who really just completely change their lives through becoming a parent. It's really, really beautiful to see.
That does sound really powerful and super impactful too. I mean, I know that's such a necessary service. And so it's amazing to hear that you're providing that kind of care for these patients. I was curious just about the details of how that works. So you go to Sheway, and then are you seeing your own kind of roster of patients, or do you just see anybody who's there at the time, or how does that work when you're actually there?
Yeah, it's a pretty sort of open schedule. It's a lot of like walk-in based opportunistic care. There's a drop-in area down below where people can come and be warm and get a home cooked meal and clothing, connect with people to help them keep their families together. Um, I know that there's a really good support for Indigenous folks, maintaining community and connection, and then the prenatal side of things. It is sometimes outreach based with really skilled outreach nurses, and a lot of it is sort of more opportunistic and less scheduled than I think you'll see in sort of regular maternity care. And then it is really working with a team. So rather than having your own panel of patients, you really sort of all come together to wrap these folks in care and help them along their journey, basically. But not as structured as other maternity care.
Mm-hmm. That sounds really cool. Yeah. I feel like we don't really learn a lot about, or we don't hear about a lot of these different paths that can be taken in family medicine. So it's just awesome to hear about that, about something that like this that sounds really unique and important that people can get into. It also sounds like having a team and having people there who are really supportive is kind of the key aspect of it, where you're able to get in and develop those skills and feel more confident in the end with the care that you're providing. If you hadn't had that team or those connections, would you have considered doing the extra training program in addiction medicine?
Yeah, I think so. I mean, I developed my skills sort of on the fly and on the job, as opposed to sort of, coming at it from, a more academic kind of focus. It meant that, community addictions is one thing. But inpatient addictions is something that I wouldn't have the skill set to do. And certainly by doing your extra year, you can definitely, do the sort of in hospital based, higher tier of more acute care for folks with addictions, as opposed to sort of the more longitudinal. Not that things aren't very intense sometimes in the community, but yeah, I think that would be one area where I wouldn't be confident to provide in-house, inpatient care. Whereas doing the +1, you certainly would. A lot of your training would take place there.
Mm-hmm. And so for students who are considering family medicine residency, do you think that there are still a few opportunities for them in terms of growth and career development, in terms of choosing their own pathway and their own niche they can be happy with in the future? It's just that we seem to hear a lot about, even on the news and things, just about how difficult some of these pathways in medicine can be, especially primary care.
Mm-hmm.
What would you say to a student who's maybe considering going into family medicine in general, to kind of give some of your thoughts on that path too?
I mean, it has been my experience that I have found the flexibility that I was looking for and that was promised to me. It wasn't an empty promise. It was, I have been able to like tailor make my entire week and career exactly how I want it to be. And done it with, I have a 2 and a 3-year-old. It's been a busy few years, and there was a pandemic, and somehow I have somehow avoided burning out through that flexibility. I think largely mitigated by working in a team, and I think you basically you find the things that you start broad, you find the things that you love. And then you build your career around those things that you love, and that keeps you coming back for more. It keeps you sort of eager to show up for work. The pandemic has been hard and challenging for everyone, and I've certainly had different, I've had different degrees of balance throughout the different locums that I've taken and the different commitments that I've had. But I've found myself in a place where, from a career perspective, I have a high degree of balance, a very rewarding, specialty that I found myself up in, or a couple specialties. And and yeah, kind of living, the dream that I had as a resident was that I would be able to do, maternity care as part of my practice. And, I found addictions throughout residency. And sure enough, here I am. And in terms of other incentives, and other, we can't really get too much into, the new funding models that are coming out and everything. But, now, 5 years into my career, having spent most of it supporting other physicians with locums for their practices, now I find myself really excited for within the next couple years, probably having my own panel at long last and really living the dream, really getting to take care of people from cradle to tomb.
That's really inspiring and encouraging as well to hear. So thank you so much for sharing that as well. It's really great to hear from a physician who's just really happy with what they do and the amount of flexibility that you have. I think that's a really sustainable way of moving family medicine forward into the future. Just having that variability and flexibility to choose what you want to do, how you want to practice. I think that's a great way to keep people engaged in family medicine and get new students and residents involved as well. I think that's very important.
And I was just going to say, just the fact that you can do that in 2 years plus practice, your training does not stop when you graduate from your residency. In many ways, that's sort of where training began. But you pick up so much from doing, and if you do a lot, then you learn a lot. So if you practice broadly, you learn about all of those different aspects that are sort of within your care. Yeah, so you don't necessarily have to choose. It's nice from that perspective.
And in the future as well, I'm sure that you can also pivot and change the way you do things. If you do get maybe burnt out or you choose to pursue something else, it seems like there's a lot of future flexibility as well to change what you're doing and make it fresh.
I think there is a lot of reinvention that is always available to you. Yeah, for sure.
Maybe you can tell us one thing or something, if there's something that you would have changed or done differently in your pathway, anything that maybe you even regret or something like that you could have done differently.
I think I've already touched on residency. I wish I'd done more rural. Maybe even in med school, I wish I'd gone a little bit more rural. I think that the learning there and the independence that you get coming out of that is invaluable and it's irreplaceable. You just don't find it anywhere else. So I think I would feel I was a little bit more well-rounded, a little bit more confident to practice, independently if I had maybe done the 4 months instead of the 2 months. So that was not a regret, but certainly advice that I give to learners. And otherwise, I see consults from hospitalists, or I talk to friends who do emerge care and while those or even palliative care. And while there was a time in my journey where I would have felt that I could do that in a passing way and pick up skills, to keep myself sort of safe in practice, along the way. The longer you go without doing things, now that I'm sort of reaching my 5th year of not having done any of that stuff, the less, the more training you need to get back up to speed. I don't regret it because it was never really, those weren't passions of mine necessarily, but certainly if I had wanted to stay more broad, I would have had to, continue to exercise those skills in the long term. I just happened to find myself into a couple areas I was really passionate about, while maintaining your full skill set of, full service family practice along the way.
That's really helpful. Right now, I'm sure that us medical students, 4th years, we're in comms right now. So I'm just wondering if you have any advice or words you want to give to those of us who are in our CARMS journey. By the way, CARMS stands for, this is for our international listeners, CARMS stands for the Canadian Resident Matching Service. It's the process through which all Canadian medical school graduates enter residency.
Yeah, I mean, don't feel. I think you're still part of the journey, right? It's nothing is final, and even once you graduate, there is still so much flexibility that we have, that we are so lucky to have within medicine. I think there's very few physicians who've had a straightforward, straight shot route and never changed, never turned the steering wheel. And so there is a lot of opportunity for continuing to evolve and continuing to change. I think you just have to have that flexibility to be willing to take those different directions as you come across them. And so I think if you do find something that you're passionate about, follow that butterfly and see where it takes you. And I think you'll be well served to sort of build a richness and a variety into your career from doing so. I'm certainly glad that, although I had done kind of the CARMS tour for both, if I hadn't had that flexibility to change my mind and really dive into family medicine, I would have regretted it. So yeah, feel free to change your mind and feel free to grow and change, and nothing is permanent.
Amazing. Thank you so much for your inspiring words and for all your insight today. I really appreciate you sitting down with me and talking with me today. So yeah, thank you so much for being here, David.
This has been great. Thanks so much, Igor.
And thank you all for listening. If you'd like to hear more from the Metamorphosis podcast, please be sure to check us out on Spotify, Apple Podcasts, and wherever else you get your podcast. Stay healthy and safe, and we hope to see you next time.
This has been a presentation of the UBC Medicine Learning Network.